All right, let's talk about ventricular tachycardia, or VT. This is one of those rhythms that, when you see it on the monitor, you have to know what to do. It's absolutely non-negotiable. So in this explainer, we're going to walk through it all: how to spot it, how to manage it, and really understand what's going on. We'll start with that one call, the one that makes your heart race a little bit too.
Okay, picture this. You get that page. Your patient's heart rate is 180. The monitor is just blaring. And when you look at the screen, you see a wide complex tachycardia. Yeah, that's a scenario that gets your own pulse up for sure. And what you do in these next few moments, it's just absolutely critical.
Now, before your brain starts cycling through a massive differential diagnosis, I want you to just stop and remember one single number. Seriously, this number needs to be burned into your memory because it's going to dictate everything you do next. So what does that 95% mean? It means this: if your patient has any kind of known structural heart disease, we're talking a past heart attack, cardiomyopathy, anything like that, then a wide complex tachycardia is VT. Period. It's VT until you can prove it's not. The odds are just so overwhelmingly stacked in favor of it being the really dangerous rhythm. Okay, so here's our roadmap. First, we'll talk about that core dilemma, why you have to assume the worst. Then we'll dive into the ECG to find the clues. After that, it's all about immediate action, figuring out the why, and then wrapping up with the long-term game plan. All right, section 1, the dilemma. Look, when you're faced with a wide complex tachycardia, the single most important thing is your mindset. You have to have a super high index of suspicion. Your default setting, your go-to diagnosis, has to be the one that's safest for the patient. And here's why that's so critical. If you mistakenly treat VT like it's something less scary, like an SVT with aberrancy, well, that can be fatal. But if you flip it and treat SVT like it's VT, that's generally pretty safe. So for the patient's sake, you always assume it's the worst case scenario. Okay, so our working diagnosis is VT. But how do we prove it? How do we find the evidence to back up our suspicion? Well, we got to become ECG detectives and look for some very specific clues that basically scream, this is VT. And here's the fundamental concept you need to grasp. Every single classic ECG sign of VT, they're all just showing you the exact same thing, just in different ways. They're proving that the atria and the ventricles are not talking to each other. The atria are just chugging along with the sinus node, while the ventricles have gone rogue and are firing off from their own crazy focus. So what are we hunting for on that 12 lead? There are 3 main smoking guns. You've got AV dissociation, fusion beats, and capture beats. Find just one of these and boom, you've nailed the diagnosis, it's VT. Let's start with AV dissociation. This is really the most direct proof you can find. You have to look really closely at the rhythm strip, like trace the baseline with your finger. See if you can spot little P waves that are just doing their own thing, completely independent of the big, wide QRS complexes. They're just kind of marching right through the VT. That's the classic sign of 2 separate pacemakers at work. All right, next is the fusion beat. This is so cool. It's basically a hybrid QRS complex. It happens when a normal beat's coming down from the atria happens to collide at the exact same time with the beat coming from that rogue ventricular spot. So the QRS you see looks like a mashup of the two. A little bit normal, a little bit VT. It's undeniable proof that you've got 2 different rhythms going on at once. And the third clue is a capture beat. Now this happens when a normal sinus beat gets really lucky. It travels down to the AV node at the perfect moment when the ventricles just happen to be receptive, and it manages to capture them for 1 beat. So, right in the middle of this sea of wide, bizarre QRSs, you suddenly see one beautiful, normal, narrow QRS. That 1 beat proves the normal conduction pathway is still there, just waiting for a chance. Okay, so you've either found your proof or you're still working with a very strong suspicion. The clock is ticking. You have to act. And what you do next all boils down to one simple, critical question. Seriously, for a second, put the ECG down. Look at your patient. Are they stable or unstable? That's it. What's their blood pressure? Are they awake and talking to you? Or are they hypotensive, clutching their chest, looking like they're about to pass out? This one assessment, stable versus unstable, is the fork in the road for your entire management plan. And here are those 2 paths, crystal clear. If your patient is unstable, low blood pressure, altered mental status, any sign of shock, you don't have time to mess around with meds. The answer is electricity. Synchronized cardioversion right now. On the other hand, if the patient is stable, they're awake, talking, blood pressure is holding on, then you have a little breathing room. You can go for IV antiarrhythmic drugs like procainamide or amiodarone. All right, you've done it. You've stabilized the patient, the fire is out, but
your job is far from over. In fact, it's just getting started. Now we have to play detective again and figure out why this happened in the first place. And the biggest question we need to answer is this a normal heart or is something structurally wrong with it?
And let me tell you, this isn't just some academic question. Figuring out if the VT happened in a normal heart versus a diseased heart, it's maybe one of the most important prognostic factors in all of cardiology. The answer completely changes the entire conversation about their future risk and how we're going to treat them long term.
And you can see the stark difference right here. You've got idiopathic VT on one side. That's in a structurally normal heart. The prognosis is generally pretty good, pretty benign. But then you have VT with structural heart disease, from an old heart attack scar or a cardiomyopathy that carries a super high risk of sudden cardiac death. And that difference completely changes the workup, right? For idiopathic VT, maybe you just need an exercise test. But for structural disease, you're looking at much more advanced stuff like a cardiac MRI or even an angiogram. Okay, let's bring it home. The long game. How do we make sure this doesn't happen again? Well, no surprise here. The strategy we choose depends completely on that root cause we just talked about. Normal heart or diseased heart. So for that idiopathic VT and normal heart, the plan is usually pretty straightforward. We can start with medications like beta blockers. If the patient is still having symptoms, catheter ablation can often be a cure. But for VT and a heart with structural disease, we have to be way more aggressive. We'll throw the book at them with all the right medical therapy for their underlying condition, but the absolute cornerstone, the thing that prevents them from dying suddenly, is an implantable cardioverter defibrillator, an ICD.
And I really want to hammer this point home. For a patient who has survived VT and has a damaged heart, getting an ICD isn't just a suggestion. It's not a nice to have. It is life-saving therapy. Think of it like their own personal paramedic living inside their chest, ready 24/7 to deliver a shock and save their life if that dangerous rhythm ever comes back. So we've talked a lot about the common causes, right? Scar from a heart attack, that kind of thing. But what happens when you have a young person with what looks like a totally normal heart and they present with VT? You have to start thinking, could this be something deeper, something inherited? Like a channelopathy or an inherited cardiomyopathy? And that one question, well, it opens up a whole new fascinating world of genetics and family screening. And it's really the cutting edge of where this field is going.